Okay. Uh, Moving on from where Chaitanya stopped, enigma of the squinting eye. So, to decode strabismus, the process essentially involves identifying the exact nature and cause of the ocular misalignment. So, we need to characterize and measure the deviation, assess binocular single vision, and then establish a strabismus diagnosis. So, due importance has to be given to the history taking part, exact the presenting complaint, ask about the time of onset, duration, whether acute or not, frequency, constant or intermittent, progression, variation, presence of associated diplopia, screen time duration in the current scenario, history of patching, spectacles, prior ocular surgery, sinus surgery, neurosurgery, and of course, birth and development history. So we see that the child, so as we take a history, give attention to the general demeanor of the child, the visual behavior, mobility, and the family social dynamics. We initiate workup with age appropriate methods of visual acuity assessment, followed by sensory evaluation to assess binocularity and stereopsis, and then motor evaluation. Again, fundus evaluation and cycloplegic refraction follow. Always imperative to take a FAT scan, familial album tomography scan. See, here the child has been maintaining the constant anomalous head posture right from her infancy into childhood. These are the different tests we have at our disposal for age-appropriate methods of visual acuity assessment. Observe the head posture, look for any head tilt, face turn, chin lift or depression, facial asymmetry, proptosis, ptosis, nystagmus, mongoloid or anti-mongoloid slant. Rule out pseudo deviations, pseudo ESO you get in epicanthus or in negative angle kappa, pseudo EXO in hypertelorism, and also look for pseudo hypotropia which you may get in ptosis. This is the goniometer, a very useful instrument to quantify the anomalous head posture. If you don't have it, you can even make use of two scales and a protractor. Very important to document the measurements prior to surgery, especially when anomalous head posture is an indication for performing surgery. Go ahead with assessment of ocular rotations, versions followed by ductions. Any asymmetry in versions means check the ductions in detail. So a thoroughly performed ocular rotation assessment will give you an idea about the commitance of the deviation. And we have these useful apps like 9Gaze app which helps in on-the-spot photographic documentation of the ocular deviation in 9-gaze position. So when you get such a picture, focus at the central image, identify the primary position ocular deviation, and then you go about serially from one end to the other to assess ocular deviation in the different gaze positions. Simultaneously, give due attention to peculiar movements like upshoots or downshoots or coexistent features like globe retraction, narrowing or widening of the palpebral fissure. Cross fixation, a frequent accompaniment of infantile esotropia, is frequently mistaken for a limitation of abduction. You can actually demonstrate normal abduction by patching one eye and forcing fixation to a favored target. You can actually demonstrate abduction in this way. And go ahead with the documentation of extraocular movements. While grading overactions and underactions to rule out oblique dysfunction, ensure that the patient fixates with the abducting eye so that the adducting eye is free to execute its overactions or underactions. This is the Hirschberg's test. We know it is a basic screening test which helps to assess the primary position ocular deviation. It requires the patient to be fixating at the central spotlight. At this juncture, let's distinguish angle kappa from tropia. Angle kappa means it is not a true strabismus and it is not related to the other eye also. So here, the light reflex is displaced from the center in monoocular viewing also. How do you confirm it? You do a cover-uncover test and you see that there is no refixation shift on doing cover-uncover test. So cover test requires a cooperative patient with sufficient vision and central fixation. In manifest deviation, you do a direct cover test, occlude one eye, observe the refixation shift of the other eye. If you don't get any shift, think of orthophoria, gross eccentric fixation, or maybe the patient has no vision at all. Cover-uncover test becomes important in latent squintophoria. Here we interrupt fusion and we observe the movement of the eye under cover. Should observe not only the movement, you see specifically the speed of the movement also, which gives an idea about the recovery and control over the phoria. Alternate cover test fully dissociates binocular fusion, determines the full amount of deviation, foria, tropia together. And thoroughly performed means it gives an idea about the fixation preferences or ocular dominance. So how to quantify your deviation? You have the prisms at your disposal, and the prism cover tests mean a lot. In large deviations, it is imperative to not to stack prisms of the same orientation in front of one eye. That leads to underestimation of the angle size. So in large deviations, you can split the prisms between the two eyes. However, it is acceptable to stack a vertical prism in front of the horizontal prism. So if you observe the image closely, you can see that the displacement of the image is grossly varied in the prism below as compared to the stacked prisms above. And we can refer to this Guyton's table to correctly quantify the total amount of deviation. Here, see, 40 plus 40 is 90 and not 80. Prism alternate cover test is the ultimate method which we resort to calculate the surgical dosage. It has to be done for near and distance in the anomalous head posture as well as in the forced corrected head posture. And when it comes to a comitant deviation, it is alright to place the prism in front of either eye and perform the prism alternate cover test. In incomitant deviations, you need to do this with the prism first placed in front of the right eye, then in front of the left eye, and thereby you assess the primary and secondary deviations. Do not miss the patterns. And in uncooperative patients or in sensory strabismus, we have the Krimsky test. It has to be done in the near as well as in the primary position. Disadvantage is that it underestimates the angle in large deviations. It's basically a glorified Hirschberg's test with the prism. When the prism is placed in front of the fixating eye, it is the modified Krimsky test. And for cyclodeviations, we have the Maddox double rod test. Older children can also cooperate for this. We place the Maddox rods in front of the eyes in the trial frame in the vertically oriented position. And the spotlight is shown. The patient is instructed to observe the positioning of the line images, which will be seen as horizontal line images. If there is no cyclodeviation, both the line images will be parallel to each other. Suppose there is an oblique dysfunction, one image will be tilted with regard to the other, and the patient has to rotate the Maddox rod until the line images come to lie parallel to each other. Disadvantage is that it does not localize the abnormal eye, and you have to club it with a fundus examination for correct assessment of torsion. Sensory examination follows. You have the Worth 4 dot test. It has to be done for both distance and near. Red-green goggles are worn by the patient, and these are the different responses. With Bagolini's striated glasses, each eye perceives an oblique line of light perpendicular to that viewed by the other eye. Assesses BSV. These are the different tests for stereopsis which we have at our disposal. Stereopsis for distance need to be measured too. You have the Randot stereo test for the same. So finally, it is cycloplegic refraction that is mandatory, because maximizing vision by dispensing the proper cycloplegic refraction itself provides for good control of the deviation. So up to 5 years, you can make use of atropine eye ointment for cyclorefraction. After 5, cyclopentalate and hometropine can be used. Cyclopentalate, beware that in some children it is associated with neurological symptoms like transient rise in blood pressure. So lower strength should be preferred. This is followed by posterior segment examination. Especially look for fundus pathology like a dragged maculae in this case, which is a neuropathy sequelae. Fundus torsion should not be forgotten. Also remember to think about eccentric fixation. So this is how you grade fundus torsion. This is the indirect fundus view. So basically, if you do a thorough basic squint evaluation, that itself will enhance the patient outcomes. Thank you.
Thank you, Dr. Samyukta. That was a very extensive talk, taking us through the unknown